Est-ce qu'on peut donner à Ling et à Heibo des cravates?
Je ne sais pas qui me les montre.
Good morning, everyone, and welcome to the demo box. We are going to get started, and I'm just asking Professor Q to have the mic. Il y a une cravate ici, and Ling Liu. She's coming? Okay, she will have the second mic. So everyone knows this noise, so we are very used to it, so no problem. We start in 1 minute. I just want to introduce the demo box, and I would like to thank Professor Jean-Louis Vincent from the ESICM as well as Comen for making this happen. This demo box has to take us from understanding what we can measure at the bedside with one aspect that is why, which is the physiology, and how, which is the outcomes. And both aspects are very important to measure, and we need to speak about that and to understand what is happening. We are very privileged to have Professor Audrey de Jong from Montpellier University Hospital. Audrey is an anesthetist and ICU specialist, and she works a lot on ventilation in different settings. You will learn from her because she has a very special style to teach, and I love that. And we are so privileged to have Professor Heibo Q from China, who is an expert. And I remember the first time I saw you, we were discussing a paper. He has, a very talented respiratory physiologist and ICU specialist, and thank you for that. And many more people, I would like to introduce Professor Xie and to give you maybe the mic to introduce yourself.
Yes, my name is Dr. Keliang Xie from China, Tianjin.
And last but not least, Professor Demoule from Paris.
Thank you very much. So I'm very pleased to be with you today. So I'm Alex Demoule. I'm professor of intensive care medicine in Sorbonne University and Hôpital La Pitié-Salpêtrière in Paris.
And you can remember him well because he has a great tie, which is very rare, I must say. So welcome everyone to the demo box, and more people will be coming. I would like to introduce the program and start. So what is this InsightBox? You have in the room specialists of the delivery of critical care, all of you. But at the same time, we do a number of things that are either recommended or sometimes not recommended, but we still do them because we are convinced that we are addressing an important issue. So today we have two words to address, the why and the how. Why will take us to understand physiology, and I think that we are the perfect people in this room for that. And the how is how we are going to change outcomes in our patients based on very simple things. So can I get the how to move the slides, please? The plick. Thank you very much. So, okay. So, is Professor Ling Liu? She will be coming. I will introduce her later, and we have introduced Professor Xie by himself, and we are delighted to have you in this room. So let me take you to a very quick and at the same time broad lecture on the safety of delivering non-invasive ventilation and high-flow oxygen in different settings. Well, again, I really want to thank both ESICM and Comen for making this happen. And this is how we are going to discuss the procedures. We can use either NIV or high-flow oxygen during or after these procedures. And what we want to do is to change outcomes. You will see in the slides that you will get by the end a number of resources in the literature that are claiming a number of results from physiological studies showing the different strand, the different interest of high-flow oxygen, for example, or sometimes non-invasive ventilation. I like this review. I like this review because thinking on it, you are really having a number of simple ideas. As you know, for each simple device, each simple strategy, we need, and this is here, high flow oxygen, we need to understand what we deliver. So we are going to have specific settings for the flow rate, for the FiO2, for the temperature, because one of the things that we do is that not only we warm, but we also humidify the breathed air, and on the type of nasal prongs. And based on that, we can either play by trying to recruit the alveoli. We can also, with the flow sometime, have different aspects when we have challenges in the way pneumonia, for example, is distributed. FiO2 is also, of course, enriching oxygen in the air. Temperature is about comfort and humidification, and the nasal prong is a quite new issue that is associated with very interesting outcomes that are not only comfort, but also sometimes a little bit more. If you want to get into the detail, you have seen this paper, which is an expert panel delivering a level of evidence for high flow oxygen, for example, in acute hypoxemic respiratory failure. And this morning, we were privileged to have the randomized control trial from Jean-Pierre Fratte and a group of collaborative French colleagues from the REVA study group showing in a large number of patients, the SOHO trial, that high flow nasal oxygen, as expected, is not changing mortality, but can significantly reduce the number of patients requiring intubation and invasive mechanical ventilation. So the strong recommendation here will be either strengthened with these new data. High flow, we will see that has been also used following extubation in the post-op period, but also in the perioperative period. This guy is called Professor Samir Jaber. He is lecturing in another room, so he will be coming in 1 hour. But him and his colleague, Professor Gerald Schank, from the same department where Audrey works, but when this paper was delivered, Audrey was a young resident, as you can see. But they are the people who first claimed that there was a need to deliver a different oxygen. What is a different oxygen? Because when you look at the comfort and the number of drawbacks from oxygen, mouth dryness, throat dryness, nasal dryness, dysphagia, throat pain, and heat sensation in the face are things that you can see with any oxygenation strategy. But they looked at the influence of flow, oxygen flow, either coming from the wall or bubbled with a little bit of humidification, that this was very much associated with one of the reasons why people were not capable to undergo high flows of oxygen with a normal or a conventional oxygen. This is one thing. But the second thing, and this is one discovery from this paper, is that the discomfort started at 3 liters per minute, which is considered to be a flow that we are using actually in the wards. Looking at that, it was quite obvious that when you do not humidify the oxygen, either at low flow, so you have this discomfort, you have a number of drawbacks, making that first, you cannot increase, but two, you are in a very difficult situation because you are adding burden to burden. The burden of acute respiratory failure followed by the burden of respiratory discomfort related to oxygenation. So these considered to be low or medium flow devices cannot deliver what we expect from oxygenation. It is interesting to say that when we started giving, and it was quite long before all these studies, when we started giving high flow nasal oxygen, we were not sure exactly what we were delivering. We were targeting to improve comfort, to increase flows, but we were not thinking on so much physiological evidence. So this is why, based on physiology, we can understand the why. Why high flow nasal oxygen is so much interesting, why it is associated with so much improved outcomes. So first, we put a catheter in the esophagus, and we are able to measure the esophageal pressure that should be considered as a surrogate, I would say a parallel surrogate exactly, than pleural pressure. And we are able to understand, and in this slide, it moves without my... We can measure inspiratory effort. Inspiratory effort is the thing that you are targeting to make the effort, and you can see that on the swings that appear on the esophageal pressure. And these negative swings are showing the inspiratory effort, but there are also a kind of premise to what's going to happen, which is respiratory exhaustion followed by intubation. So this is why high-flow oxygen, by delivering high flows, is capable to reduce inspiratory effort, and by a simple math calculation, we can estimate the reduction of work of breathing. We can, of course, improve oxygenation, reduce the minute ventilation, because we are feeding the respiratory drive, as we are able to give an oxygen flow that is over the patient respiratory drive, we are able to reduce the minute ventilation, because we are able to feed as much as needed the patient. And this is, in addition to that, giving a quite constant FiO2, because as we are competing with the patient drive at the same flow, we are able to deliver what we expect in terms of FiO2. So this is another study, again by Tommaso Mori, a very talented guy working in Milan. And this is a study where different oxygen flows at the same FiO2 were compared. And again, you can see that you are going to reduce inspiratory effort, improve the CO2 clearance, like in a tracheal gas insufflation, having a kind of PEEP effect. This is quite controversial, but there are data that are going in that sense, that we can improve lung aeration and, of course, improve PF ratio by nourishing the breathed air by more oxygen. And this is the first Florali trial. I wasn't able to include the paper that was shown this morning because the PDF was discharged only this morning. So this morning, the same others, the same investigators and the same group published a paper where not only the high flow nasal oxygen was associated with a reduction in intubation and mechanical ventilation, but also the data are very clean. They are including, of course, we're in 2026, so all our studies include COVID-19 patients, but this is very interesting to see that at that time we have a reduction in day 90 mortality, which was quite unexpected and not shown in the trial published this morning. If we want to have more data, we need to get now data on safety of delivering high-flow oxygen in different settings. Here, we are in a VATS lobectomy, and we compare patients who underwent the procedures with either conventional oxygen therapy, COT, to high-flow nasal oxygen. And interestingly, the outcome here is another surrogate marker of respiratory exhaustion, that is the diaphragmatic displacement. And you have here a worldwide expert of diaphragm, and he is part of the maybe 10 people in the world who described the ventilation-associated diaphragmatic injury himself, Samir Jaber, Martin Dress, Yuan Golliger, and maybe a number of people in the world. And still you can see that using high-flow oxygen in this postoperative setting, not only we were able to improve diaphragmatic function by decreasing diaphragmatic dysfunction and reduce post-op complications. Another study now in apneic oxygenation, and I'm referring to my colleagues here who are experts of apneic oxygenation. You both published papers in this setting, and this is a randomized control trial with high flow versus low flow, versus standard of care. And interestingly, in this trial, you can see that endotracheal intubation was made in a way that was much more safer using high flow oxygen, at least 20 liters per minute. Here it is during bronchoscopy, and this paper published in the White Journal again shows that there is little clinical interest, but when you measure SpO2 and other respiratory symptoms, you can see that there are some interest in doing that. why this paper has targeted COPD patients? Because COPD patients and immunocompromised patients are on the top of the list of patients who deteriorate their respiratory status following bronchoscopy. So this is a very large randomized control trial published in the European Respiratory Journal just last year. 600 patients randomized between low flow and high flow oxygen. And you can see that the number of events, hypoxemia events, was lower in the high flow group, but also hypoxemia overall during bronchoscopy was much lower in the high flow group compared to the low flow group. Another very important paper, and maybe you know these investigators, you know them well? Where do they work? You know the center where they work?
Yes. The center may be Shanghai and Zhejiang. They did the sedation patients using the high flow treatment to prevent the hypoxia.
Okay, and they are well known in China?
Yeah, in China. Yeah. Yes, they are anesthesiologists.
The amazing thing is that when we are meeting with teams, Chinese teams working on respiratory physiology, we have groups of clinical investigators, professors, but also respiratory therapists that are playing a big role in your country. And this is a very important paper because it's adult obese patients, one of your specialty, where 984 patients. This paper was published in the British Medical Journal, and you can see that overall hypoxemia was reduced from 20 to 2%, and there were other signs that were very, very impressive. So this paper published last year in the BMJ is showing that in each of the subgroups, the intervention was very positive, showing the benefit from high flow oxygen in this very specific setting of obese patients undergoing procedures. And this is another paper. I'm not going to get into the details. And now extubation. I'm closing to the end of my presentation. And extubation has been a very important topic. It has been addressed by one of the French team from Arnaud Thiel, who has contributed a number of substantial papers in the field. And here you can see that it is a small physiological study of NIV versus NIV and high flow oxygen in post-extubation period, and patients were randomized in a crossover way. And you can see that you can both measure inspiratory effort, tidal volume, and you can also address a different issue. But based on the how, so the physiology, we can understand how we are going to design a randomized control trial by delivering very specific ways to provide non-invasive ventilation, maybe sometime with a higher PEEP or sometime in a prolonged sessions. But this study shows also the interest of combining high flow and NIV to reduce efforts and to improve tidal volumes. And this is how, from understanding better physiology, we design better trials. Of course, there is no direct relationship between the two, but this is a very important paper from the REVA group, the same French investigators working on mechanical ventilation and respiratory issues, where you see that the number of patients needing reintubation is much lower when you give both high flow and NIV as compared to high flow alone, showing that it should be now considered as, at least in high-risk patients, as part of the standard of care. This is also a way to address the results on whether patients had hypercapnia or no hypercapnia. Another very talented colleague from Spain, Professor Hernandez, working on the benefits from high flow to prevent reintubation in very high-risk patients with obesity. It is interesting to see that there were no significant differences between NIV and high flow oxygen, but still these data are also feeding their ongoing trial that is now almost at the midst of the inclusions, and will certainly show very important results. I'm passing on that because I would like to discuss the last part of my presentation about the use of non-invasive ventilation. This is the HAPPEN investigators, a group from China, very well known, very well considered, and considered to be talented. You can see that some of the names are also very much into into we work with, like for example, Professor Ge Huiking has been working with us in the FRM3 study, and she has been really amazing. I think that they are both pulmonary and ICU, right? And they are working on the two fields. So this is about intensity inspiratory positive airway pressure, where you would adjust the pressure on the expiratory tidal volume to have it either between 10 and 50 milliliter per kilo, as opposed to 6 to 10 milliliters per kilo. And the primary outcome was the need for endotracheal intubation in the hospitalization overall. And the trial was terminated early because of the benefit of the strategy, showing that intubation was lower with the high intensity NPPV as compared to the low intensity NPPV, even though we need to make the difference between the need for intubation as compared to endotracheal intubation. And there are many papers like that that are making quite different outcomes when there is a clinical indication and you escalate ventilation as compared to other settings. Here, a paper that is also has changed a lot the way pre-oxygenation is delivered in the perioperative, in the emergency department, where pre-oxygenation during intubation is either NIV or conventional oxygen therapy. And you can see here that NIV was considered to be a very interesting opportunity. And you have a paper that you published about the number of cardiac arrests. It was, I think, your PhD student, and she published a paper on the number of cardiac arrests during non-invasive ventilation. It's not so low, but when you look at the number of times we are using NIV in our studies, it's very important. And I'm passing on that because I would like to discuss this important paper that is a secondary analysis of the oxtube obese, and Professor De Jong, who is here in the room, has conducted not only the oxtube obese paper but also this sub-study on a multi-center randomized control trial, and I'm passing her the mic to explain the paper.
Thank you. So I can stand maybe. So we compare inpatient with obesity to prevent reintubation, critically ill patients, non-invasive ventilation versus oxygen, whether high flow or standard oxygen. Here, in the general result was that non-invasive ventilation was superior to prevent treatment failure than oxygen, whether standard or high flow. And here we focused on post-operative critically ill patients, and we found exactly the same results. And non-invasive ventilation performed even better when people were with morbid obesity, so body mass index higher than 40 kilograms per square meter. Thank you.
Thank you very much, Audrey, and congratulations for your papers. This is the same data, and again, an open randomized control trial, 7 ICUs, a number of patients receiving non-invasive ventilation with a very nice intervention that we are keeping doing all the time, but never really properly assessed, which is low versus high PEEP. And you can see that not only an IV failure, but also there were other interests in providing a higher level of PEEP in these patients. When you look at the low PEEP group, for example, they needed more prolonged ICU stays, and they also needed more ventilatory support. This is an interesting trial that was published last year and has reshaped also avenues for research regarding the use of non-invasive ventilation. And I would say that here high-flow nasal oxygen was considered to be non-inferior to non-invasive ventilation, and the trial has been completed in almost all these situations. But in the future, we will look at more papers published showing the data groups by groups just showing and demonstrating evidence that the different groups cannot be considered as only one, and acute hypoxemic respiratory failure need to be seen differently if the patients are immunocompromised, if they have a cardiogenic pulmonary edema, or if they have a COPD. And in immunocompromised patients, and with Alexandre, we did a randomized control trial on high flow oxygen in immunocompromised patients. And in immunocompromised patients, this trial cannot be conclusive about the non-inferiority of high flow oxygen compared to non-invasive ventilation. And I'm sure that in a close future, we will see more trials on NIV in immunocompromised patients. I'm going to stop here because we have to discuss, and I would like to know if any of you want to make a comment or ask a question or maybe share any experience. I see you as someone speaking a lot. No? No? Okay. Any question, any comment before we move to the next presentation? Yes, please.
Yeah, this morning, the high flow study for the respiratory failure patient with immunocompromised, the patients with same mortality, but with if the patient use high flow, so with compare with the routine care, yeah, the intubation, the rate is low, but the mortality is same. Do you think it suggests for the patient with high flow, maybe the intubation is delayed? So the intubation rate is low, but mortality is same. Why? Maybe.
Yeah, thank you very much. It's very complicated because the problem of all the non-invasive respiratory supports is that they may delay intubation. In this trial, I'm not sure, so it was presented this morning, so we have to really go into the data to understand what happened, but I asked to the authors if the explanation of the discrepancy between the reduction in intubation rates without reduction in mortality could be that it delayed in intubation, and they said no, probably not. So not in this trial, but this is a risk. This is a very important risk. But I think that in terms of physiology, this risk is higher with non-invasive ventilation than with high flow, because high flow is supposed to be more respectful of the lungs than non-invasive if tidal volume is too high with non-invasive. So when it's non-invasive with high PEEP and low tidal volume, it seems to be very protective, like in the trial you showed. So that might be a very good option. Otherwise, high flow is probably a very good option.
So then, Alex, I have a question for you, because we are here to discuss the safety of delivering ventilation and the safety of delivering non-invasive ventilation. So I'm having a patient undergoing an IV, and I'm thinking on what you just said, respecting the lungs and not adding ventilator-induced lung injury under NIV. So what are the settings that you are looking at when the patient receives non-invasive ventilation to avoid having either VILI in NIV or sometimes PSILI in NIV? And please, what does mean VILI and PSILI?
So VILI is ventilator-induced lung injury, so meaning that this is the ventilator of ventilation, but ventilator, let's say, which is that this is the ventilation delivered by the ventilator that injures the lung. And because, in general, because it's a too high tidal volume with respect for the compliance of the lungs of the patients. And somehow, sometimes a too low level of PEEP. And the PSILI is the patient self-inflicted lung injury, which is, I think, the idea that the patient with acute respiratory failure has a very high respiratory drive, And these high respiratory drives translates into very high inspiratory efforts and in turn generates very high tidal volume like this. And this enhance the inflammation and edema within the lung, which leads to a vicious circle because the more the damage to the lung, and in terms the drive increases and the tidal volume increases, and then the damages, the lung injury increases. This is a vicious circle. So regarding settings, I think that we need to really differentiate COPD patients and patients with a de novo acute hypoxemic respiratory failure. Because as you showed, this brilliant paper in the JAMA, in those patients, the COPD patients, we can give to those patients tidal volume as high as 10, 12, even 15 milliliters per kilogram predicted body weight. And in some cases, it might be very beneficial because it avoids intubation. So I think that lung protective ventilation is not a big issue in COPD patients because those patients have very high respiratory system compliance. So for those patients, if you say, ask my settings, I will target quite high tidal volume, like 10 milliliters per kilogram, even 12, no problem. And I think these make really, with non-invasive, I mean, non-invasive, of course. Not.
Maybe you want to take the mic. Yeah. We all want to laugh with you.
Yeah. Thank you very much for this session. So I come from China and from the Prof. This is my boss. Yeah. So I have a question, maybe both for you. Beyond your research, we know we very like to high flow in clinical work, but beyond your result, how do you select the high flow or the standard therapy at the 10 millimeter per minute for your patient? Routine use. Yeah.
So your question is how I select. So I was with COPD patients, so it's only non-invasive. Now I don't use that much high flow in COPD. In COPD, I do non-invasive.
So this morning the high flow, this morning release in
Yeah.
the journal medicine.
So no, the
For the all the acute respiratory failure patients.
so for this morning the paper they published was in for only acute hypoxemic respiratory failure, so no COPD. It was only pneumonia, viral pneumonia, bacterial pneumonia. So in these patients, I prefer doing high flow. So I do high flow. If the patient needs more than 6 liters per minute standard oxygen, in my clinical practice, I use high flow. And then I give the highest possible flow that the patient can tolerate, targeting 50 to 60.
The good thing is that this discussion could last for 2 days. So please ask Professor Vincent and Comen to extend the time of the demo box for 2 days. So thank you, everyone. And please keep your questions for the next presentations. And I'm delighted to introduce a superstar in this demo box. And please introduce yourself and where you work. I think it's important that people can contact you after. They can contact Alex. I'm going to sell his phone number, and as well as Audrey.
Okay, thank you. Good morning, everyone. I don't know, do you know Comen, the corporation? Yes, little? Do you know? A little, yes. The Comen corporation maybe is very strong in China. For the high flow treatment, maybe for this ventilator, maybe it's very simple. So I want to introduce how to measure the FRC. Yes, for the V8 model. Maybe it's very important for the protective ventilation. This is my name from critical care medicine and anesthesiology from Tianjin Medical University General Hospital. This, okay. For the Comen cooperation in China, maybe the life support many operations or the diagnostics and medical imaging, 3 areas in medicine. This is the contents for today's FRC. What's the FRC? And the module introduction and operation and auxiliaries and the important what's the FRC? Maybe everyone knows the FRC. Yes. Functional residual capacity. Why we measure the FRC, or why is it important for FRC? From this figure, do you know where is the FRC? What's the? That's right. Yes. The total line volume. Yes.
That stays in the lung, and that is not used while breathing. I think it's the residual volume. I don't know if it's the same thing in English or not.
Yes. Why we measure the FRC? For the patient, maybe the COPD or the lung collapse is very important for the protective ventilation. In clinic, there are many methods to measure the FRC. The standard, maybe the Gordon standard, maybe the CT scan, and the nitrogen washout and wash-in methods, and the mechanical flow measurement, or the EIT, or the ultrasonic. I don't know. For the FRC measurement, maybe in the respiratory department, for the lung department, lung function department, yes, maybe commonly use the nitrogen washout and wash-in methods. Yes, you know the nitrogen washout is very positive validation for the CT scanning, and helium dilation may be very important. For the Comen machine, it's used the gas dilation methods. It's used the nitrogen dilation. No interruption for the ventilator with the working, and no additional gas source, and no patient cooperation needed. But for the measurement, we should keep the patient sedation. Yes, this is the principle for the FRC measurement. Is the gas dilation based on baseline the nitrogen concentration. We use the washout and wash-in phase, and use this maybe it's very complicated for everyone. Yes, this is the algorithm for the parameter 1 is the begin and end nitrogen concentration. And the ventilator volume for the nitrogen. And the third parameters. In this machine, they can how to measure the FRC. Yes, permit oxygen sensing and high accurate CO2 monitoring and water rep components. Use this machine, we did many data and maybe to prove, yes, like this, learn, practice, and improve. And at the end, for accurate, there are 5 animal experiments and human subjects and more than 1,000 days. From the human clinical results, we find the FRC measurement is very accurate and very stable. How to operation? Step 1, there's a module for the machine. It's very simple. Yes, this is the navigate for the FRC function. There are many the Chinese FRC 功能含气量。But we can measure the FRC once time or continuous. We can measure the FRC once time, maybe in clinic or outpatient. In our ICU, maybe we use the continuous measuring the FRC. There are many accessories for the machine. The CO2 drying tube and the filter tube and the CO2 side stream sampling line. I think it's very important for all of you to measure the FRC in clinic or for the patient protective ventilation. There are many advantages for this machine. Maybe the warming up time maybe is quick, less than 3 minutes. And there are many advantages. Maybe compared with the GE operation or the drug operation. Okay, last slides. Welcome all of you to our conference next month. Yes, April 17 to 19 in Tianjin, China. 2 cities, 1 dream. Thank you. Next speaker is from China, Professor Ling Liu. Welcome.
Hi. Can we switch to my slides? Okay, hello everyone. I'm Ling Liu from Zhongda Hospital School of Medicine, Southeast University of China. And I'd like to show something about this machine of the transpulmonary pressure clinical applications. And I received the support. And as we all know, mechanical ventilation in critical care remains the mainstay of the respiratory support of ARDS, of other kinds of patients. And the big problem is in ARDS patients, a ventilator always induce some kinds of lung injury. And we have three domains of lung injury. What do we the first is biotrauma. That means the patient has excessive strain, and we should try to limit the transpulmonary pressure, limit the plateau pressure to avoid high strain. And the volume trauma, that means the patients receive excessive strain, and we need some kinds of small tidal volume and limited our driving pressure, and the athletic trauma. That means we need a appropriate PEEP. So our challenge is to balance the necessary support against the potential of the physiological damage during mechanical ventilation. And as we all know, the stress, that means the pressure generated within the lung tissue when the lung is inflated by mechanical ventilation. And we can assess with the transpulmonary pressure. The transpulmonary pressure equal to the alveolar pressure minus the plateau pressure. And clinically, we use the plateau pressure, minimum the alveolar pressure, and the esophageal pressure, minimum the pleural pressure. And what is the clinical importance of the transpulmonary pressure? And we can see here, this is a prospective multiple center cohort study enrolled 395 ARDS patients. And they found that the driving transpulmonary pressure was a good predictor for the outcome of ARDS patients than only the driving pressure. So maybe measure the esophageal pressure and calculated the driving transpulmonary pressure is an important thing in ARDS patients. And the other use of the esophageal pressure is to measure the transpulmonary pressure to setting PEEP. This is the EXPRESS trial and did by Daniel Taylor. And we can see that we use this table at the end, aspiratory occlusion. We measure the transpulmonary pressure and guided our PEEP setting with different FiO2. And this, the primary outcome of this study was oxygenation. We can see the PEEP titrated by the transpulmonary pressure improved the PF ratio, improved the compliance, and all the physiological parameters also have a trend to decrease the mortality. After that, they tried to did another study to confirm this reduction of mortality, improve the clinical outcome. And they did another EXPRESS-2 trial, and but there were no significant difference in end aspiratory transpulmonary pressure on average over the first 7 days, and if not, there was no difference in survival in both groups. However, the role of, if we consider the role of esophageal pressure monitoring clinically, maybe we can assess the lung and chest wall elastance, and we can measure the respiratory effort and monitoring the patient's ventilator asynchrony. If we have the esophageal pressure, we can see directly what the beginning of the decrease of the esophageal pressure and what the time of the flow increase, and we can find the gap. That's the patient-ventilator interaction asynchrony. And the most important, we can also set PEEP with titrated by the transpulmonary pressure at the end of expression. There are 4 steps to measure this pressure, the esophageal pressure. First, we should prepare the patients, prepare the tube, and second, we insert the catheter, and then we measure the position of the catheter, is it right? And we measured the esophageal pressure, we calculated the transpulmonary pressure, and the last step is maintain or remove this catheter. First, step 1, for patients' preparation, we should exclude some patients with esophageal, with some contradictions. Maybe the blooding, the gastric blooding, something like that, and maybe some injury of the face, of the nose, and some air leak in the ventilator endotracheal tube circuit. And the contradictions also include the severe coagulations, esophageal injury, the risk of worsening injury, and recent based skillful surgery, something like that. And we should prepare our tube. There are several tubes we can choose. We can see that we will consider about the balloon materials and the available catheter tabs and the workflow position. Can we show our tube? We have the Comen tube. We can use this for measuring the esophageal pressure, the gastric pressure, and even feeding. And but come here, give me the tube. And we can see that the tip of the tube is very soft and a very big hole for feeding. And after we prepare the patients, the equipment, the tube, and everything, we go to stage 2, the catheter installation. And first we selected a good catheter, appropriate catheter, then insert with nozzle or oral route. That depends on what we have. If a patient was intubated, maybe we can put it in from the nose. And first, we can calculate the lungs, how long we put the catheter inside the patients, from here to here to here. That's very easy, just like each gastric tube. And we can first we catheter to appropriately, maybe 40 to 45 centimeters, but it's quite dependent on how long the patient is. And we should verify, the important thing is we should verify the gastric position first. If the balloon is in the good position, we can see the oscillation of the cardiac here. And then we put the tube further to the gastric and confirm the, oh, okay, you translate it to me. Confirm the patient, the tube is in the esophageal and gastric, and then we draw back. Here we can see this is the esophageal pressure, this transpulmonary pressure. Okay, can we go back to our slides? Shall we go back to our slides? Okay, how to confirm the right position of the balloon is very important. And we just do the occultation test, verify the correct position, and fill the optimal volume of gas in the balloon. And we can see here, sorry, here. Oh, here. Here, for the Comen catheter, we insert 8 milliliters of air and draw back 5. That means we left 3 milliliters of air. For the Cooper catheter, we just maybe left 1 or 2 milliliters of air to fill the balloon. And as we all know, if the balloon pressure is appropriated, the balloon pressure is very important because if the pressure is too high, it's will to create some artifact. And it's too low, it cannot transfer the pressure from esophageal. So if the balloon pressure is appropriated, we can see the measured esophageal pressure is more closely approximates the dependent lung, the pressure in the dependent lung zone. This line is here. And waveform, we can see here, interruption recognizing the overinflation. Overinflation is not good because the pressure in the balloon itself is too high. We can use the baseline esophageal pressure to check that. If the baseline is too high, and that's mention us that it's overinflation of the balloon. Typically, the baseline of the esophageal pressure is around 3 to 5 centimeters water, something like that. And before we measure the pressure, we should check the correct balloon, the balloon position. And we have patients with spontaneous breathing or just control patients. And we use the end expiratory occlusion. And when the patients have spontaneous breathing, when the patients breathe and during the inspiration, we can see the decrease of our esophageal pressure and of the airway pressure. And we measure the delta airway pressure and delta esophageal pressure. If it's nearby 1, from 0.8 to 1.2, that means okay, the position is good. And if the patients did not have spontaneous breathing, we occlusion and we just push the chest, and we get the change of our airway pressure and the esophageal pressure. We also have this ratio, the delta P airway pressure and the delta esophageal pressure ratio. And this ventilator, we have this screen. This ventilator can automatically do the automatically occlusion test and providing delta airway, change of airway and change of esophageal pressure change. And we have this screen here. If it's between this blue bar, that's okay for our balloon position. And the third step is measure the pressure. We can measure the end inspiratory transpulmonary pressure. We do inspiratory occlusion and the end expiratory transpulmonary pressure. We did end expiratory occlusion, and we can also calculate the driving transpulmonary pressure. For each pressure, we have some physiological targets. And during the maintaining of the catheter, we should be cautious about the injuries caused by the catheter. And if we did not measure, we can draw back the air from the balloon. And after the next measure, we did again. We checked the balloon pressure and did everything. And the maximum position, the day is 29, last 7 days for this catheter. So that's all, thank you.
Congratulations. We are now having time for questions for Professor Liu. I have so many questions.
Thank you very much. I have one question. What is your main indication to use catheter? Is it for some selected patient, like obese patient? Is it for managing very severe ARDS? Or what is your main indication?
Thank you, Samir. This is a good question. I think we use the catheters quite different from the Euro countries because we don't have that much of obesity patients. So the most patients we use was a very severe ARDS. So we cannot maintain the oxygenation. We want to titrate the PEEP. We want to do some optimal measurements and optimal settings on our ventilator. That's the most things. Yeah.
Ling, I have a question on the side effects because when you start using as a first pressure for it's so interesting to explain that to the residents, to use that for the patients, that you can consider that you are taking it to the standard of care. Are there any side effects? Is it dangerous to insert an esophageal catheter? Are there contraindication? Because we are here to discuss about safety.
Yes, thank you for the question. I think it's a big problem. We should train the residents, the interns, to put this catheter. Safety is the most important thing. I think we have a case, but as we know that when we put the catheter and the saturation go down, it's put not in the esophageal, in the trachea. So I think we should train while and to in each step measured, keep an eye on the residents to do this. That's make the patient safety.
So this is not a research tool, it's a tool that you can use at the bedside to improve ventilation management. So who here is used to use esophageal catheter for the clinical practice? Giacomo, can you tell us, for example, the last indication, who was the patient?
Thank you. Well, the last one was a patient with, the last one was of the burn patients from Crans-Montana. So this patient had, of course, burns, and so we had the idea that his chest wall was stiffer than expected. So we wanted to, he had ARDS, he was on ECMO, so we wanted to know how to set PEEP, and so we used that to, let's say, rule out to do a partition mechanics and see whether the chest wall had an effect on the transmission of pressures. So that was my last patient.
In our unit, we use it systematically in obese patients. In obese patients with ARDS, really change our practice, and we really change our PEEP level setting, Elie. Usually we put 10, between 10 to 15, and now we have patients need 20, 25 sometimes, and we care about just hemodynamic effect, but it's really nice. I want to ask a question, another question. Do you have some... Do you have some indication for difficult weaning patients?
Difficult weaning? If I get the question, is do we use esophageal catheter for the difficult weaning patients? I think it's very few in our clinical practice because difficult weaning first we can measure the esophageal, and we should measure the esophageal function, but we use ultrasound, we use a NAVA tube. We do not use esophageal because I think it's more completely than other methods.
So Professor Grasselli is the president-elect of the Italian Society of Anaesthesia and Critical Care, but most importantly for this session, he also was the leading author of the RDS guidelines. What is the state of events? So what should we recommend on the use of esophageal catheter, for 100 patients ventilated on our ICU? So how many should get it?
Well, thanks, Elie. So as you know, in the guidelines, we were unable to make a recommendation in favor or against the use of PEEP setting, let's say PEEP setting based on respiratory mechanics, but we meta-analyzed only basically the two studies with esophageal pressure. So because as you know, the Vent 1 and 2 had conflicting results, but we're not going to discuss that. But I think that the patients where we should use the esophageal catheter during the acute phase, so in ARDS patients during the acute phase, while they are on controlled mechanical ventilation, it's mostly in obese patients and in patients where you think that the chest wall is stiffer than expected, and so then a greater fraction of the pressure that you apply at the airways is not transmitted to the lung, but it's used to inflate the chest wall. Then I have to say that during the weaning phase, or at least when you switch from controlled to assisted ventilation, then that's a very, I can say, easy way to use it to measure the swings of esophageal pressure during inspiration, because that is not exactly PMUSC, but it's very close to PMUSC, and so this gives you the measure of the effort that the patient is doing. So if you combine this with the ultrasound of the diaphragm or the eye catheter or what you want, but this it helps you to understand how much effort the patient is doing for each breath, because sometimes this is not clear from the screen of the ventilator. So sometimes you think that you are protective, and then you see that the patient is developing 15, 18, 20 centimeters of water of negative pressure at each breath, which is clearly not protective. So in those patients, maybe it's better to go back to assisted ventilation or to do something to reduce the effort.
Thank you very much, Giacomo. As you know, there are now ongoing trials on the use of esophageal catheter in patients with RDS, in patients ventilated for different conditions, as well as in weaning. And we will be able to speak more about that. I think that we have 2 more minutes before going to 2 very hot topics in this demo box. One will be, I don't know how to present Professor Jaber, because he is not only the chief editor of the ESICM journal, but he's also a crazy physiologist working on ventilation. You know, they are working since, hey, Bo, for how long have you been working in respiratory physiology? 25 years? 30 years? Alex, 20? 25. 30. So, and I'm sure Giacomo, who is younger than everyone here, has been working for at least 25 years. So, and even Audrey, who is, you know, the junior of the excellent people in my country, she has been working at least 15 years on respiratory physiology. So I would like to go to this part of the room, and maybe you have the experience of working with Elie Azoulay. So what, the answer is why? Why don't you have the experience? Please.
Because I hasn't has experience of using this catheter yet. So my question is for the professor. For the obese patients, what's the difference you found before and after you use this catheter?
Asking you about obese.
Yes, obese patients. Yes, I found that.
So who of the 2 is going to address?
So we really changed our practice with the obese patient due to the chest wall, which is really different in the obese patient than in non-obese patients. So we try to have an airway pressure minus esophageal pressure positive, or at least 2 or 3 centimeters of water. So we need to have this. We need to have sometimes to increase the PEEP level above 20 centimeters of water. This was demonstrated in some 20, and then it's really changed our practice. So we increase it until we have no side hemodynamic effect. If you have side hemodynamic effect, we stop to increase it.
Keep the mic and you go to the screen. The floor is yours.
It's my turn? Is it down? Oh, sorry. Is it okay? No?
So do you have use this catheter for the pram positioning patients? No, not yet. Okay. No? Okay. Okay, thank you very much.
I'm Professor Samir Jaber. I work in Montpellier, France, and I'm the chair in Anaesthesia and Critical Care Department of the University Hospital of Montpellier. So, I will speak about improving patient safety in anesthesia mechanical ventilation. The green? This one?
Yes, it doesn't work. Okay.
It works.
It works.
Okay,
This is
this one. This is back, okay. I will just summarize in this slide the main modification of the respiratory function in the perioperative period. First of all, you have the residual effect of anesthesia analgesia, which lead to decrease the cough and the upper airway with the pain, and you have the stress of the surgery, and all of this induce a restrictive syndrome with a decrease of all the lung volumes, the VC, the FSC, and the tidal volume. And then this is associated to diaphragm dysfunction in the postoperative period with atelectasis. So all of this lead to hypoxia with respiratory failure and sometimes pneumonia or transfusion-related acute lung injury. And this is sometimes enhanced by the fluid overload with the TACO. So this slide summarizes all the effect and then when you can try to stop it. As you see, the atelectasis is probably one of the major places when you can decrease. Sorry. This is a normal lung, and our objective in anesthesia is try to avoid this change by RDS1, as you see in this slide. And this is the CT scan, as you see. This is an operating room in our center, which is a double liver and kidney transplantation. And as you can see, is totally similar than in ICU. In around 12 hours, as you can see here, you have the different condition than in ICU. You have hemorrhagic shock, you have vasoplegic shock, you have septic shock, and you have cardiogenic shock, etc. during 12 hours during this type of surgery. So during this surgery, the lung can be the target of different stress and you can change, and our objective is to avoid to transformation. This nice trial showed something which is the risk and the consequences of postoperative pulmonary complication. And as you can see, the first one is the pulmonary edema, atelectasis and pneumonia A, this one. But the main major message of this trial is the reintubation for post-acute respiratory failure increased the risk for hospital death by 72. So the mortality rate in this trial was 16% for the acute respiratory failure versus 0.3%. One major message is to try to avoid to put a high lung volume. And the lung volume should calculated according to the ideal body weight, not the actual body weight. So why? Because this comparison between a patient with obesity and patient without obesity, you can see the volume of the lung are exactly the same if the height are the same. One way to calculate in a very simple way in the OR is to calculate it for the men height minus 100 or height minus 110 for the woman. But for the obese patients, patient with obesity, you should increase PEEP due to the change of respiratory mechanics. This is very important to see. So, how we can modify and how we can decrease the postoperative complication after surgery? We can have the patient risk factors, but these are poorly modified. We have the surgical risk factors. Try to have the best surgeon. This is very important. And you have the anesthetic risk factors, and I will present you some ventilatory strategy to decrease the risk of complication. We developed with our team in France, with Emmanuel Funtier, Audrey De Jong, and all our team, the POP ventilation concept. The POP ventilation concept is a perioperative prophylactic positive pressure ventilation. The concept is derived by the Lachman, open the lung and keep it open by positive ventilation. And this will start in intra-ventilation operative period, but also in pre-operative. You should try to have a pre-oxygenation with positive ventilation, and you should have in intraoperative lung protective ventilation with tidal volume between 6 to 8. Remember 7, if you want just to remember one number. 7 PEEP, and recruitment maneuver. These 3 associated, not only one. And in the post-operative period, you have also positive ventilation with non-invasive ventilation, especially in patients at high risk, such patients with obesity. This is a main paper, and you see the different strategy. We started very early and after surgery. This is one landmark study showed by Ruska. We showed that just after induction, you see here the atelectasis that you have just after 3 minutes pre-oxygenation, you have atelectasis in the dependent part of the lung. And if you use CPAP, just to avoid this, you can avoid atelectasis by maintaining the lung open. CPAP allows to avoid de-recruitment. It's not recruitment, but avoid a de-recruitment, as you see here. So it's directly correlated to the oxygenation level. And in this trial, 20 years ago, we demonstrated that non-invasive ventilation can be used in patients at high risk of complication during intubation procedure, and we performed this with non-invasive ventilation for the pre-oxygenation. And as you can see here, in the y-axis you have the oxygen saturation, and in the x-axis you have the different time of the intubation procedure. And as you can see, this is a pre-oxygenation with spontaneous breathing with the balloon, and you have a decrease around 80 centimeters of water at the minimum level during the endotracheal intubation. And if you use non-invasive ventilation, you decrease this value and you have less oxygen desaturation and you have more safety during the intubation procedure in this hypoxemic patient. This was true in ICU patients with hypoxemia, but was also true in obese patients in OR. We demonstrated the same thing, and here we use the oxygen expiration, and we have more FiO2 than the balloon oxygen with non-invasive ventilation. This now was a standard pre-oxygenation in different centers in the obese patient using around 5 to 10 centimeters of water pressure support ventilation and around 5 to 10 centimeters of PEEP. So this is the recommendation of the Anaesthesia Society that recommend to use NIV or CPAP should be considered as useful adjunct during intubation during the general anesthesia induction. And then more recently, with the team with our team, with Audrey de Jong and our colleague from China, 2 centers in China and 1 center in Boston from Daniel Telmore, we performed this OptiMask study. The objective is combined 2 pre-oxygenation method. Is a combined face mask with high flow oxygen therapy in comparison to the classical face mask alone. The objective is when you have here, first of all, a pre-oxygenation with face mask before laryngoscopy in patient with breathing. You have first this, and the major interest when you use high flow oxygen therapy, as you see here during the apnea oxygen phase, you have no breath of the patient, but you have the TRIV, which is the transnasal humidified rapid insufflation ventilatory exchange, and this you can have always oxygenation continuously. So performing this, we showed in this trial, including 450 patients, that we can have the primary endpoint, the lowest end-tidal oxygen within 2 minutes after induction as a surrogate of the quality of the pre-oxygenation, which is available in anesthesia machine, not in the ICU machine. And this showed really a better value for this value, 91% in comparison to 89% in all non-selected patients. This showed it's a proof of concept study, and it's very easy to use it. So after this, after intubation, what about the FiO2? The Anaesthesia Society recommend to use the following information. The FiO2 should be set less than 0.4, less than 0.5 to avoid high oxygenation and the atelectasis of denitrogenation. Therefore, use the lowest possible FiO2 to achieve SpO2 above 94%. This is very important to not to have a 100%. What about intraoperative ventilation? During intraoperative ventilation, the objective is to have this, a low tidal volume, a PEEP around 6 to 8, and recruitment maneuver. The three together, which it's combined. Which mode can be used? About the mode, pressure or volume is exactly the same if you delivered the same level of assistance. This is very important to see. And sometimes you have some mistake made by some papers when they compared the Pmax by the P-plat of here. You should have the comparison between the Pmax here with the P-plat to have exactly the same alveolar pressure. This is very important. Sometimes in the past we have studies said, oh, pressure control is better than volume control, but they did not compare the same pressure. So when you are in volume, check the pressure, and when you are in pressure, check the volume. This is very important. Use what you want, but be sure that you should have a safe method. We performed to demonstrate the interest of the bundle, as I presented to you. We compared the bundle of all the three together in comparison to the standard of care at this period. And this study was published in the New England Journal a few years ago now, and we have a significant difference of the post-pulmonary and extrapulmonary complication by the non-protective ventilation from 28% to 11% in the high-risk abdominal surgery patients. This is a very important change. But to do this, you should apply all together. The bundle combine the three interventions. If you use only one or two, you cannot reach this decrease. For example, at the same period, this trial was published by the European Society. It's a Provelo trial, which compared high PEEP level versus low PEEP level. The high PEEP level is around 12 centimeters, and the low PEEP is around 2 to 4. And no significant difference was observed. Why is no difference? Because they used only the PEEP high versus low. They did not use the same than in IMPROVE when we used the bundle. So PEEP alone, the message is not always sufficient. And then this is probably my favorite physiological study, showing in the three groups of patients, one first group using PEEP alone, one using recruitment maneuver alone, and one using both combined recruitment maneuver plus PEEP, which is open the lung and keep it open. This is when the patients are awake. This is three different groups of patients with obesity. This is immediately after induction in balloon standard oxygen. You see we have, for all the groups, you have atelectasis, and this is when you use PEEP alone after induction. This is recruitment maneuver alone. And when you have both, you have no atelectasis. This is a very nice demonstration to explain why recruitment maneuver works only with higher PEEP. And this is very important and to explain this, why PEEP not works alone or why recruitment maneuver not works alone sometimes. And this 20 minutes later is the same results. So we don't have a CT scan at the bedside. We can use waveforms. This is the same thing. You see here, this is the airway pressure, the flow pressure, and this we performed in this RDS patient, the same thing. This is the setting of the PEEP level. This is a CPAP, and after the CPAP, you see you have an opening of the atelectasis. And one way to see this very simple way, what is it? You see what happened here? From here to here. You have a decrease from the plateau pressure. This is a simple way. It's responder patients of the recruitment maneuver. If you have this, you have an improvement of your respiratory system compliance. And if you don't have this, that means the patient is not a responder. Then avoid to make a recruitment maneuver in the case. When to perform recruitment maneuver? Always in a non-hypovolemic patient, so you should check the fluid loading of the status of the patient. This is a very, very important. It's sometimes very dangerous. After a loss of lung volume, such as after tracheal intubation, after tracheal aspiration, after disconnection from the ventilator, and during laparoscopy, it should be repeated every 30 to 45 minutes. So what's the recommendation today? We recommend the ventilator should be set between 7 to 8 and PEEP at 5 centimeters of water. This was what I report to you. PEEP, what about the PEEP value? The PEEP should be individualized to the patient in order to avoid increase in driving pressure while maintaining a low VT or using sometimes a spontaneous a catheter balloon. Just to show you, if you use a low PEEP, you have a lot of atelectasis. If you have high PEEP, you have high side hemodynamic effect, so you should personalize your PEEP. How we do this? You have different technique. You have the minimized driving pressure. You have the maximized dynamic lung compliance, which is a couplet one. You have the lowest value of regional ventilatory delay index, or to obtain a transpulmonary pressure using esophageal pressure. This is what we discussed previously. Nicely, so we can go fast, is to have, then if it's not positive, you have collapse. If positive, you have opening atelectasis. This is a case of, like just we showed it previously, a pressure, transpulmonary pressure, which is negative, as you see here. So we increase the PEEP, you see from 5, and then we increase 5 is decreased. And then when we reach 10 centimeters of water, you have a positive transpulmonary pressure. In this typical case, to use esophageal catheter as demonstrated previously. So in this trial, it was a negative trial comparison in obese patient, the PEEP value. So what happened is probably that not possible to have the same value for all the same patients. It's like when you put an antibiotherapy, it's not the same for all the patients. You should individualize the PEEP. And more recently, this paper published this year, in a sample way, you said that every one of you, more than 20 years ago, you make physiology. In a sample way, you calculated the PEEP by BMI divided by 3, in a sample way. And the others perform this, BMI divided by 3, and when we calculate this, we have exactly the same value. It's incredible, very, very incredible. We use catheter, etc., and then you can calculate this. You have the same value. You have here the value obtained with a classical one using esophageal pressure here, according the BMI. In y-axis is the PEEP value, and this is BMI divided by 3. And as you can see, this is available in non-obese patient and available in obese patient. And this was true when you start and perform percentage of pixel in the CT ATI here, the electric impedance tomography. This is very incredible. So you can now perform just BMI divided by 3. It's available. It's a very simple way to have an appreciation. For example, if you have a patient with BMI by 30, probably the PEEP value should be around 10 centimeters of water. And if it's 40, it's probably around 13 centimeters of water. And this individualized meta-analysis showed that each time when you performed a strategy of individualized PEEP, you have better outcome than without individualized PEEP. This is our clinical published trial with Emmanuel Futier, Audrey de Jong, and collaborator in ICM, which was the first randomized control trial which the PEEP was driving by guided by the driving pressure, to have a driving pressure less than 13 centimeters of water. And unfortunately, there was no significant difference in abdominal surgery patients. This was really disappointed, and it's negative trial. And this was also confirmed by, at the same period, this trial from published in the JAMA at the same period, which is also negative, and it's very similar. And then when we can explain that it's negative trial, probably driving pressure less than 13 centimeters of water probably is not enough, and probably we should have less than 10 centimeters of water or 8 centimeters. Or we can probably use for the future the mechanical power is published by Past Gattinoni. We showed that we should take into account the tidal volume, the respiratory rate, the PEEP value, and the airway pressure. And then now we have a study which will start at leading by Audrey Dejean, which is called Improve 3, which mechanical power guided PEEP ventilatory strategy. So to finish, this is for the non-invasive ventilation after surgery. I think we have time. We showed that we can use NIV after surgery in acute respiratory failure after abdominal surgery, and we can decrease reintubation from 46 to 33% by non-invasive ventilation. This was true in abdominal surgery, but it was true also for cardiac surgery or thoracic surgery. So the message about NIV, you should always, after post-operative acute respiratory failure, always eliminate a surgical complication. This is very, very, very important. And high-flow oxygen therapy or non-invasive ventilation should not delay the time of reintubation. So if the patient status improve, you can follow non-invasive ventilation. And if the patient, the status doesn't improve after 1 hour, for example, I don't know, we can discuss with Alexandre 1 hour or 30 minutes, 2 hours, it depends on the patient. Probably you should stop and probably consider intubation. So in conclusion, protective ventilation should be used for all patients with a low tidal volume around 7 minutes per kilogram of ideal body weight. You should consider recruitment maneuver to avoid electrotrauma and open the lung and keep it open with the PEEP. And then low plateau pressure and low driving pressure, avoid barotrauma. And always you should try to have the more rapidly spontaneous breathing to avoid diaphragm dysfunction and atelectasis. Thank you very much for your attention.
Thank you very much, Samir. I think that we are quite contained in terms of time. We have a presentation from Professor Ling Liu, and then we have the debate on the optimal modalities for assessing weaning. So we will have 3 questions. 1, 2, and who? And 3.
Thank you very much. Thank you very much, Samir. I loved your talk. I loved the BMI divided by 3 story. So because you guys use balloons a lot, esophageal pressure a lot in the ICU, not only in the operative room, but in the ICU, do you think that this recipe, BMI divided by 3, which seems to come from the operative room, would it work in the ICU? Could you validate this with your esophageal pressure measurements?
Short answer.
No, we don't have validation. We plan to do it, but I think it's very interesting to do. It's a very simple way.
Ling, a very quick question for a very short answer.
Do you use the transpulmonary pressure to titrate PEEP during surgery and after surgery for the weaning of obesity patients? And what PEEP cutoff, maybe less than 10, less than 8, you should distribute the patients?
Thank you. No, we use only esophageal pressure in patients with obesity with ARDS in ICU, and in OR we don't use esophageal pressure in OR, but we put high PEEP in very obese patients.
And the last question.
Hello, Jaber. I have a question. When we use the recruitment manure, I know that in ARDS patients, the recruitment manure at high PEEP levels and long duration, it may be harmful. So what do you think about in patients with surgery for the recruitment manure?
Post-operative.
Yes, we think we should do recruitment maneuver after surgery, especially abdominal and thoracic surgery, because we have a lot of atelectasis, and we performed probably the sample way. We have CPAP 40 centimeters during 20 seconds. Sometimes it's enough. or sometimes by the balloon.
Thank you very much, Professor Jaber. So there were 3 questions plus 1.
Yes, yes. In literature, we frequently saw that we should adjust tidal volume according to the predicted body weight. You have referred ideal body weight, and between these two, which one should we choose for?
In life, it's always the ideal.
Yes.
Yeah, always the ideal. Yeah, yeah. Yeah, but titrating PEEP, yeah. Otherwise you use the Montpellier algorithm, you divide the body weight by body mass index by 3. So Professor Liu from she's an amazing respiratory physiologist, and she's going to do a short communication before we go to the last discussion about the optimal modalities for weaning.
Okay, thank you. I promise it to be very short. And the topic is unmet needs in operation room and ICU ventilation, and it's a disclosure. And as we all know, lung protection strategy is both is equal important in operation room and ICUs. But there are several differences of patients. During the surgery, the patients have shorter periods of exposure to ventilation and more healthy lungs and more favorable respiratory care, respiratory system compliance. But the 3 aspects we should concern is who, for which benefit, and how. And as we all know, for the lung protection in ICU, we start from the low tidal volume and then switch to limited the plateau pressure, limited the driving pressure, and further switch to lower mechanical power. And for the PEEP setting, a lot of randomized control trials, they focus on the physiological parameters help us setting PEEP. For example, the transpulmonary pressure, the plateau pressure, the PF resource, something like that. But until now, we did not have an optimal method to setting PEEP for ICU patients. For the patients in the operation room, Samir also mentioned this milestone research, and the bundle of a low tidal volume, higher PEEP, and a recruitment maneuver decreased the post-operative compliance complications in this trial. That's the IMPROVE trial. And after that, the most recently published the IMPROVE 2 trial. In this trial, we can see that we use the driving pressure as physiological parameters for setting PEEP. We want to switch the driving pressure to the operation room ventilator settings. And we can see that physiologically, the PEEP is pretty high in the guided PEEP group. That's 15 centimeters of water. It's much higher than Samir's research. It's 6 to 8, I think, yeah. And in the control group, it's only 5, but it's a 10 of harm in the intervention group. And we can see that the post-operation complications was 25.7 in the intervention group and 20.2 in the control group. And I will not go to details. There are several factors for the disappointing results, and Samir also mentioned this. And so I think this research just suggests that the PEEP selection based only on the minimized driving pressure, that means the best respiratory system compliance may not always be the answer. And several experts gave some key principles to get the intraoperative mechanical ventilation, include targeting the lower driving pressure and individualize the PEEP titration and lower tidal volume, and even we should measure the mechanical power and not too high respiratory rate, and even the limit of the chemical power. That means we will not use very high FL2. And to make it simple, that's the figures from this editorial, and we can see that all these parameters, all these settings on ventilator are associated with the lung protection in the surgery patients. And another choice for us is to calculate the individualized treatment effect. During the randomized control trials, we always focus on the average treatment effects. Sometimes we use a subgroup to detect the patients who will benefit from this kind of setting, who will benefit from that kind of setting. But as we all know, each patient has multiple baseline characteristics. So if we can calculate the individualized treatment effect based on the characteristics of each patient, we can find which patients can benefit from maybe high PEEP, maybe low tidal volume, maybe recruitment maneuver. And so we have a lot of method modules to calculate this kind of individualized treatment effects. And in this slide, in the future of the mechanical ventilation, not only, no matter in operation room or in ICUs, I can show here the future is AI and the machine learning for individualized care mechanical ventilation. The ventilator calculated the parameters, and they calculated by the AI, and they set the personalized ventilation, and they tracing the patient ventilator interactions, tracing every parameter, physiological parameters, and they give the real-time monitoring and timely risk prediction. They give feedback. That's mean the closed loop ventilation. And for this kind of protective ventilation, the patients will have lower risk and faster intervention and optimal ventilation. So for this is the last slide. I think the urgent needs in operation room and ICU ventilation is we should build a system like this, the AI-guided closed-loop ventilation for lung protection for all of our post-operative patients, operative patients, ICU patients. I think that's the future. Thank you.
So AI is today. What is the future? Well, I love the individual treatment effect because besides personalizing medicine, it also helped you use trials to speak more than comparing a Q2 square to compare the main outcome. Are there any questions for Ling Liu? And if not, I would like to know who in the room use spontaneous breathing trial in patients who are deemed to get extubated. SBT. SBT? SBT. So you don't? Oh, I was anxious. So who doesn't use SBT? Because it's not SBT versus others. Huh?
Well, it depends. In some patients, we don't do SBT. A patient who was ventilated for, let's say, 24 hours for an intoxication, for toxic coma, we don't do SBT. Generally, we do SBT for an post-operative patient with short duration of intubation. We don't do SBT. I would say that we do SBT for patients, for sure, for patients ventilated for more than 48 hours, something like that, and with possible risk factors. But there is some patients who don't need SBT, I think.
I'm interested, when you don't do SBT, does it happen that you do nothing, you just extubate? We are in 2026. Oh, you are laughing. I'm coming to you in a few minutes.
Yes. How to define that the patient needs a SBT? I would say that for
we are deciding to extubate extubate the patient after 3 days of mechanical ventilation. So there are different options. One option is just to take out the tube. And this still exists today in 2026. Other people are setting the ventilator in a way to provide minimal support and assess whether the patient is eligible for extubation.
Yeah.
Between the two.
Yeah, maybe we can some patient we intubated when we run the patient. Before the extubation, the mechanical support level, maybe PSV, maybe is equal to the SBT, maybe.
So how do you set, I'm very interested by that.
Maybe for some after surgery patient, operation surgery. Yeah, yeah.
Support in a way to understand
Maybe PSV 7 to 10.
so
7 to 10, maybe. Yeah. We can say this patient we intubated for this patient.
what's the level of PEEP when you
Actually, this is I think this is SBT.
You're too good. You're too good. Come.
So for this patient, I think is actually the SBT.
Okay. So when do you extubate without doing SBT? You just take
No,
out
I think in this patient, this kind of patient after the operation, I think before the extubation, the PSV support is equal to the SBT. So I think the definition for this.
So before getting back to Professor Demoule, Ling, I have a question for you. Do you use AI or any automated system that helps you to assess whether the patient is eligible for extubation?
Yeah, we use AI, but not only for the extubation or detect.
We are here only for extubation.
Okay, I will say that I think we insert a big module of AI in our systems in our hospital, but for AI we just build a module, AI calculated module for the extubation. We use Mimic 4, and our data is submitting right now. And
so you use it at the bedside?
Yeah, not at the bedside,
Okay.
just publishing, and we inserted in a ventilator. Try to do this. We are on the way, but not clinically used right now.
Okay, so AI-derived database to understand what are the criteria making extubation doable. You remember 20 years ago, the first automated system of extubation. You were a teenager. So tell us about it.
So it was the smart care, no? Yes, the smart care. It was not AI. It was a closed loop, and it was based on SpO2, respiratory rates. Yes, it was an algorithm, but yes, but it was a programmed algorithm. We knew what was in the algorithm, which is different from AI. We don't know what's inside. So, and the thing is that it was not that much used. Despite positive results, various RCTs that were showing patients were extubated more quickly with the smart care. It did, and not reintubated, actually, yes. Finally, it was not that much used. It didn't translate to daily clinical practice. There were some barriers. I think clinicians were not ready for that.
Well, the last time you wanted to set up, because he is an amazing physiologist doing a lot of clinical research. So the last time you were thinking on doing a study on extubation. So did you want to compare methods or to improve one method, like for example SBT? Because I know that you are using SBT a lot.
Yeah, in bedside, we all for the mechanical ventilation longer than 24 or for more than 2 days, maybe we routinely use SBT routine. But we, as we know, the PSV is better than TPs in many studies. But a recent study, physiological study shows PSV 7 or 10 centimeter water is over support. compare with post extubation. So maybe TPs or PS0, PEEP0, maybe is better. Better. No, say PEEP0, PS0. It's just like that's the respiratory load that is like the post extubation. So I think is a new data to support the TPs or maybe the PS0, but I'm not quite believe that. I'm not really believe that result. I think we should do the more for the difference level or difference disease, different kind of disease. What kind of the maybe maybe it's different. Yeah, maybe it's different. Yeah, so more study research.
Any experience with SBT or another winning techniques at your institution? Yes?
Well, I work in pediatric ICUs, so there are not many algorithms that are designed, and there are practical considerations that make TPS trials very difficult in small babies, just because the resistance in the tube, the length in the tube versus in a very small tube means it's very difficult for a small child to breathe on no support whatsoever. So we do tend to wean them to the lowest support whatever. We sometimes drop them down to just CPAP to see if they don't have a massive leak, which can also happen in pediatrics. And then our population's pretty much divided between those who will have good lungs coming in and hopefully will extubate relatively quickly, and those who have very bad lungs coming in are graduates of our NICU academies and will probably need step-down care onto either a CPAP or NIV, which we tend to use using their same ventilators, which makes it a little easier.
Thank you very much. Any other experience? So we go back to the basic question. Samir, do you extubate like that? Because I think that we don't have the comparator in terms of extubation that has been clearly set up in clinical studies.
Thank you. Just think what is exactly spontaneous breathing trial. Spontaneous breathing trial is just a trial that evaluates the inspiratory effort or the work of breathing performed by the patients after extubation, just immediately after extubation. To anticipate, it's not really a test that should say the patient will successful extubate or not. It's just work of breathing trial. It's a physiological data. And we recently showed that the data mainly came from study performed more than 25 years ago. So we performed this study now recently with the new generation of the ventilator, where you have a very small workload for the inspiratory valve, etc. And we showed that probably the best technique in terms of physiology is the TPs in the majority of the patients, or it's the PSV0 and PEEP0 for the majority of the patient, except for the COPD patient. Except it's always the same, always 20 minutes, yes. Yes, this is probably the best one, and now we perform the randomized trial, yes, because the ventilator changed around the last years. So this is very new. The paper published very few months ago, 1 year ago, in the ESICM journal. And then it's very interesting to say if you use PEEP or PSV at 7, you not discharge the patient. You help the patient. So probably you don't evaluate very well the work of breathing after surgery. The only one is need more is a COPD patient. The only one type. That means that all the patients are different. It's not.
Audrey, I have a question for you. So when you anticipate extubation and you think that you're going to use high flow or NIV after extubation, do you proceed differently? Would you extubate the patient quicker because you know that you would rely on NIV, or high flow oxygen?
Yes, absolutely. When I expect to use especially non-invasive ventilation, even if the spontaneous breathing trial is not so good, I will extubate the patient if other parameters are okay. So if the fluid balance is negative, if the cough is okay, if it's not in a neurological way, if the patient is conscious. So there are many things to take into account, and SBT is only one thing more to me. But I will perform SBT when I do not want to really want to extubate the patient, because I have argument not to perform extubation.
So extubating versus ruling out. Any comments or questions? Yes, please.
I have just a small question for patients for weaning. We do have encountered some patients in ICU, especially some elderly patients or some patients just recover for a long time intubation, but the patient's relatively weak. So maybe for this kind of almost past SBT, so what do we do? You will just intubate the patient and continue with the high flow or NIV. So what do you do? And I want to, because some of the patients of their family, they do not want to undergo tracheostomy. So I want to, what you will do? What's the actually successful rate? I mean, extubation rate for this kind of patient, and what do you generally practice?
I'm sorry, this was my question. So the last part of the discussion today, in 2 minutes, would be about what is acceptable in terms of extubation failure. Because if you don't run any risk, your patients are going to be on vacation for 2 weeks, and you're going to have maybe 200 patients per year in your ICU. So this is an important point that you mentioned. So who is using any kind of device, AI-driven or anything, to make decision to extubate? And Giacomo, do you think that there is a place for any device?
I can tell you what we do. I mean, our common practice is to do SBT with pressure support and with low level of PEEP. For devices, like 7.5, 7.3? Usually, I have to say that with PEEP, we're more liberal, and we tend not to reduce too much from the, let's say, the standard PEEP that the patient had before. So we can sometimes extubate patients also with, let's say, higher levels of PEEP, especially obese patients, for example, and then of course, we give non-invasive ventilation or CPAP after extubation, and for pressure support, 6 to 8, something like that. Devices, well, we've tried the EDI catheter, for example, and so, for example, NAVA in difficult to wean patients. I have no experience with the smart care or with other closed loop. Well, NAVA in a sense is a sort of closed loop, but I mean not let's say AI or algorithm-driven closed loop systems of or IntelliVent, for example. So we're not really using that. So this is our practice. Not.
But you have the mic. What's the extubation failure rate in your ICU? And what do you consider being acceptable and even desirable?
In our ICU, I would say. Pardon? Yeah, less than 5% for sure.
And would you accept to increase extubation rate to reduce length duration of mechanical ventilation?
I think that we are a bit going to that direction. I mean, because we are increasing the use of non-invasive support post-extubation, so which means that, of course, some patients will fail. So maybe, I don't know, but I would say that for now we are set below, let's say 5%, something like that.
Thank you. Alex, 5% extubation failure rate?
So we have a 9% extubation failure rate. I would say that below 5-6% is really low. So possibly some patients undergo too long invasive mechanical ventilation, and I would say that more than 15 is a real issue because we know that yes, the mortality of patients who fail extubation is quite high.
Unless, as said by you, unless you have very old colleagues or very specific patients. What is your extubation failure rate?
Yeah, I think it's around 10%. 10%? Yeah.
Okay, and you monitor that as being guiding and driving your winning strategies?
Yeah.
Samir? The same. Hebo? The same. Yeah, but you know, sometimes the boss and the people working at the bedside say different things. So, I know you're a very IT person. Any device to guide that?
Thank you. Before I majored in anesthesiologist, maybe 5 years ago, I went to the ICU. 5 years ago, I don't know SBT. Okay. Yes, all the patients after surgery, we can extubation maybe depend on muscle power and enough volume and the awakeness. But in ICU, I know all the patients maybe maybe the winning for using the SBT. I don't know. But why don't you use the SBT? Maybe because, after the patient awakeness and intubation, maybe analgesia or analgesia, maybe, and we can use the analgesia, no pain for the patient, and he can ventilation smoothly. Yes, maybe I think we have the drugs or some technique. I think we can do keep it calm and ventilation, and then it's safe. And when the extubation, maybe it's okay.
Thank you very much. I think that we have now reached the time where we need to close this demo box. I would like to thank very much ESICM, Professor Jean-Louis Vincent, and all the organizing team, as well as Comen for making this happen. To thank our experts for the excellent messages and the how and the why. I think that now we are committed to work together, to develop clinical studies together, because otherwise we will be left with different experiences and we will not learn so much from each other. So this is what we can hope. Thank you very much. Thank you, everyone.
Thank you, everyone. We have prepared a free lunch here, so feel free to take one and water. And I would be very appreciated if you can scan the QR code for a survey that we know how to improve ourselves in the future. Thank you very much.